Welcome to the deep dive. Today, we're plunging into something truly intricate, really vital, the world of oral and maxillofacial surgery. Think about the kind of precision needed, the foresight required when dealing with the unique anatomy of someone's face and jaw.
Absolutely. It's incredibly complex work, and patient safety, well, that's always paramount. Successful outcomes depend entirely on understanding that unique anatomy.
And that's our focus today. How three-dimensional imaging, specifically things like CT scans, computed tomography, and maybe more importantly for this field, CBCT, cone beam computed tomography,
Yeah.
how they've just completely changed the game.
Right. Changed everything from diagnosis to treatment planning and even the surgical applications themselves.
Yeah, and our deep dive today comes from a really comprehensive chapter by an expert in the field. So our mission is to unpack how this tech moved dental care away from, well, sometimes a lot of guesswork, honestly,
Mhm.
into this realm of amazing precision. Getting that true reality of anatomy for every single patient. We'll explore how it's changing planning, communication, the works.
It's a fascinating journey from those early days.
Definitely. So to really appreciate where we are now, maybe let's start back then. What were clinicians working with before all this 3D tech?
Well, the early days, you were mostly looking at conventional two-dimensional x-rays.
Hmm.
Panoramic views, the little periapical ones. And they were useful, sure, for certain things.
But limited.
Oh, very limited. Think about it. You're trying to understand a complex 3D structure from a flat 2D image. You get distortion, things overlap.
Mm-hmm.
You just couldn't accurately assess, say, the real spatial relationships or, crucially, bone width. It's a bit like navigating in the dark sometimes.
Right, you can't see around things or judge thickness properly. So then CT comes along. That must have been a big step up.
It was. Computed tomography, CT, started making inroads in dentistry in the late 1980s. But these were big medical-grade machines, usually in hospitals.
So not something in your average dental office.
No, not at all.
Mhm.
Patients had to be referred out. But it did allow for a much deeper level of diagnosis than those old 2D films.
Okay, so you get these better slices, but the real revolution seems to be when you could take that data and build a three-dimensional picture, something interactive. When did that happen, and what did it really change for the doctors?
That was the critical leap, yeah. As computing power got better, we could move from just looking at 2D slices to creating interactive 3D models. That's when clinicians could really appreciate the reality of anatomy, like the author says.
So you could spin it around, look from different angles.
Exactly. You could see structures in ways you never could before. And for things like dental implants, this was huge. It dramatically improved planning and, importantly, the communication between the person placing the implant, the surgeon, and the dentist restoring the tooth. It took a lot of the guesswork out of complex procedures.
Okay, so it's powerful stuff. Why didn't it just take over immediately? Sounds like there were still hurdles.
Oh, definitely hurdles, big ones. First, the cost of those medical CT scans was really high. Then there was the inconvenience for patients having to go to a hospital or radiology center. And frankly, dentists and surgeons needed specific training to really interpret and use this 3D data effectively. So yeah, powerful, but not very practical for routine use.
Right. Which sets the stage perfectly for cone beam CT or CBCT. What was it about CBCT that made it such a turning point? Why could this tech make it into the dental office?
CBCT it was designed for this kind of application. It addressed those barriers head on. The machines were much less expensive than medical CTs. The image quality for the jaw and face area was excellent. And a really big factor, the radiation dose was significantly lower.
Still need to be careful, I imagine.
Absolutely. The LRRE principle, as low as reasonably achievable, always applies. You only scan when necessary, but it was a major reduction. And, crucially, the machines were smaller. Small enough to actually fit in a dental office. That made all the difference in accessibility.
That is a huge difference, bringing that capability right to the point of care. So what's the potential here? How big an impact does the expert think this will have long term?
Well, the author is pretty emphatic about this. They see CBCT as one of the most significant developments, period. Something that's shaping how surgical and restorative work is planned, communicated, executed, and will continue to do so for years. They even say its ultimate use is really only limited by the clinician's imagination.
Wow, okay. So it opens up a lot of possibilities. Now, getting practical again, you get one of these scans, CT or CBCT, you have this raw data. How does that become something a clinician can actually, use?
Right, the raw data needs processing. If you get a scan done externally, it often comes on a disk, maybe with its own viewing software. If the office has its own CBCT machine, the data gets processed right there on a computer workstation.
And the software turns it into specific views. What are the main ways you look at this data?
Yeah, the software generates four main views typically. You get the axial view that's like slicing horizontally, the panoramic view, which is like the unrolled jaw view people might be familiar with, but reconstructed from the 3D data. Then there's the 3D reconstruction itself, the model you can rotate. And finally, the cross-sectional views, like slicing vertically through the jaw at specific points.
And those are the building blocks for everything else.
Those four views, yes. They're fundamental for analysis, for diagnosis, for talking with the team, explaining things to the patient, making the plan, and then actually doing the procedure accurately.
The interactive part sounds key, though, not just static pictures.
Oh, absolutely transformative. You can interact directly. Change the grayscale to see bone versus soft tissue better. Scroll through slices to trace a nerve, for example. Or with the more advanced software, you can actually simulate placing an implant, measure distances, check angles. It's like a virtual rehearsal before you even start.
Does the size of the area scanned vary?
Yes, definitely. Depends on the machine and the sensor size. That's called the field of view, or FOV. Some machines have a large FOV, letting you see the entire maxillofacial complex, jaws, sinuses, joints. And the software can present this data in different ways. Like for the TMJ, the jaw joint, it can automatically create views focused right on the joints themselves, highlighting the key landmarks.
So it's useful for way more than just implants then. The outline mentioned quite a few different procedures.
Oh, the applications are incredibly broad. Various software packages can take this CT or CBCT data and use it for planning all sorts of things. We mentioned implants, but think about orthognathic surgery, corrective jaw surgery.
Right, major realignments.
Exactly. You can plan those bone cuts with incredible precision beforehand. Or distraction osteogenesis, where you actually grow new bone. You can simulate the whole process. It's also invaluable for dealing with impacted teeth, planning bone grafts, diagnosing TMJ problems, sinus lifts. The list just goes on.
That really sets the stage for seeing it in action. We've got the theory, but the real impact is on patients. We have these 4 case studies lined up that sound pretty dramatic, starting with the 10-year-old boy, who apparently had a hidden surprise.
Yeah, these cases really illustrate the power we're talking about.
Okay, so this boy comes in, referred by his orthodontist. He's got a baby canine tooth still hanging around, and the permanent one underneath is stuck, impacted horizontally. What couldn't the old 2D x-rays tell them?
The big problem with 2D was figuring out the exact spatial position of that impacted tooth. Was it towards the cheek? Towards the palate? How close was it really to important things like the roots of other teeth or the floor of the nose or the sinus? You just couldn't reliably tell from a flat image. It was ambiguous.
But the CBCT cut through that ambiguity.
Completely. It gave them that reality of anatomy, showed the mixed dentition clearly, confirmed, yes, the permanent canine was horizontal, showed exactly where the baby tooth was, and critically, its precise relationship to those vital structures, floor of the nose, maxillary sinus. It also showed the root tip wasn't fully formed yet, which is important for planning the timing of treatment.
And then came the surprise.
Yes, this is where 3D often shines, finding things you weren't even looking for. While reviewing the scan, they found an extra tooth, a supernumerary tooth, what's called a mesiodens, hiding near the front teeth.
Wow.
The axial view showed it was on the palate side, really close to the incisal canal. It's a delicate spot with nerves and blood vessels. And the cross-sectional views, they showed it was actually rotated 180 degrees vertically. Just incredible detail.
So what did finding 2 impacted teeth and knowing their exact locations mean for his treatment?
It meant everything. It allowed for an accurate diagnosis of both issues. It facilitated much, much better communication and planning between the oral surgeon, the orthodontist, and the restoring dentist. Led to a proper, comprehensive treatment plan and ultimately a successful result that just wouldn't have been as predictable, or maybe even possible, based only on 2D images.
Amazing. Okay, case 2, the mandibular mystery. A 60-year-old man missing some back teeth. What brought him in, and why the need for 3D?
He came in for an evaluation because he was missing 2 lower first molars. His regular dentist took a small 2D x-ray, a periapical, and saw something suspicious, a dark area, or radiolucency, near where the teeth were missing. It looked like there was bone loss, and it seemed close to the main nerve in the lower jaw, the inferior alveolar nerve. That combination immediately flagged the need for a CBCT. Too many unknowns.
And surprise, surprise, another incidental finding.
You guessed it. These scans are thorough. The panoramic view, reconstructed from the CBCT, showed a very clear, well-defined lesion and abnormality over in the area of his lower canine and premolar teeth. Totally unexpected. It just underscored why getting that comprehensive 3D look was so important.
So what did the detailed CBCT views show about this unexpected lesion?
Drilling down with the cross-sectional images gave them the full picture. They could see the exact size and extent of this lesion within the jawbone. It was clearly defined, sitting between the hard outer cortical plates of the mandible. They could measure it precisely in all 3 dimensions. The 3D view also confirmed how close the original problem area, the missing molar site, was to the mental foramen, another nerve opening.
Did they check if it was affecting nearby teeth?
Yes, the axial view showed it had a solid front border, and by comparing measurements to the other side of his jaw, they confirmed it wasn't expanded the bone outward. And importantly, pulp tests on the nearby teeth showed they were still healthy and vital.
So they have all this detailed info. How did they proceed with treatment and follow-up?
Well, the beauty of digital data is you can share it easily. They emailed the scan data to the local surgeon. After review, they decided on surgical excision. They removed the lesion and filled the space with a bovine bone graft material. The biopsy came back as an odontogenic keratocyst, a type of cyst that, while benign, is known for being quite aggressive locally and having a high chance of coming back.
So follow-up would be really important.
Crucial. And because CBCT has that lower radiation dose compared to medical CT, it's much better suited for follow-up scans over time. They did scans, saw the bone graft had filled in nicely by 5 months, and thankfully, even at 3 years, there was no sign of recurrence.
It sounds like knowing the exact size and nature of that lesion beforehand was key to avoiding problems.
Absolutely. That 3D view gave a complete understanding of its scope. It allowed the surgeon to plan the removal properly, to be thorough, and avoid complications that could have been quite serious if they'd only had a partial picture from a 2D X-ray.
Okay, on to case 3. Rebuilding for a smile. This is a 17-year-old girl missing a front tooth, a lateral incisor since birth, and she had thin bone, a concavity. Again, 2D wasn't enough.
Right. Congenitally missing teeth often come with bone deficiencies. In her case, the bone was narrow, and there was a noticeable dip in her facial profile there. Standard 2D X-rays just couldn't give the necessary information about the bone quality or, crucially, the width available for placing an implant.
So CBCT for planning. What did the different views reveal this time?
The panoramic view gave a good overview of the potential implant site. But it was the axial view, looking down from the top near the crest of the bone, that really highlighted what the author calls the restorative dilemma.
The restorative dilemma, what's that?
It's about the transition. Dental implants are basically round posts. But natural teeth, especially front teeth, aren't round where they emerge from the gum. They have specific shapes, often more triangular or oval. Making that round implant look like a natural tooth emerging from the gum, especially when the bone is thin, is a real challenge. It affects the final look, the aesthetics.
And this is where the author's concept, the triangle of bone, comes in. Tell us about that.
Yes, this is something the author developed back in the early 90s. It's a way to evaluate the implant site using the cross-sectional view. You visualize the available bone as a sort of triangle. The idea is to place the implant optimally within that triangle, bisecting it, essentially, to maximize the amount of surrounding bone for support and stability. It keeps the focus on the final goal, the tooth, not just burying an implant. The implant has to be positioned to support a natural-looking tooth.
Makes sense. So they use this concept and then move to virtual surgery, like a practice run on the computer.
Exactly. Using sophisticated 3D planning software, they could take precise measurements directly on the virtual model of her jaw. They virtually place a correctly sized implant, a 3.8 millimeter one in this case. They even simulated performing a bone graft to build out that thin area, virtually positioning the graft material and even simulating fixing it with a tiny virtual screw.
And visualizing the final tooth position.
Yes, they could simulate the abutment, that's the connector piece, between the implant and the crown, and see how the final tooth would emerge through the gum tissue, ensuring it looked natural and lined up correctly.
The visualization tools sound amazing. Making bone transparent,
Yeah.
clipping things away.
Yeah, the software has some really powerful tools. Clipping lets you virtually slice through the bone model to see internal structures or check clearances. Selective transparency is incredible. You can make the outer layer of bone see-through, revealing the implant positioned underneath right next to the roots of the adjacent teeth. They could virtually prepare the graft site, simulate roughening the bone surface, decortication, and even use a tool to calculate and visualize the volume of graft needed to fill the defect.
So it's like building the whole thing virtually before you even touch the patient. The power of that pre-visualization must be immense.
It really is. Think about it. Every single piece, The implant itself, the bone graft, the abutment, even a virtual representation of the final tooth, all visualized, analyzed, tweaked before surgery begins. It's incredibly valuable for educating the patient so they understand the process. And it's a fantastic communication tool for the whole dental team, ensuring everyone knows the exact plan. It just takes away so many unknowns.
Okay, our final case, comprehensive mandibular planning. A 62-year-old man currently wearing full dentures wants implants. This sounds like a big undertaking. How does 3D imaging help plan something this extensive?
It's absolutely essential for something like this. A key first step involves using what's called a scanning template. It's basically a copy of the patient's denture, but made with a material containing barium sulfate, like barium POC, which shows up on the CBCT scan.
Why is that template so important?
Because it links the desired tooth position, where the teeth need to end up for function and aesthetics, directly to the underlying bone structure visible on the scan. It provides critical landmarks. Without that link, you could place implants perfectly in the available bone, but they might end up in a position where you can't actually build usable teeth on top of them. They wouldn't be within the restorative envelope.
Got it. So template first, then scan. And nerve mapping must be critical in the lower jaw, too.
Absolutely paramount. The software tools allow the clinician to meticulously trace the path of the inferior alveolar nerve within the jawbone and pinpoint the location of the mental foramen, where the nerve exits near the chin. Avoiding injury to these structures is crucial to prevent numbness or other complications.
So once the nerves are mapped, they start placing virtual implants.
Yes, they virtually position the implants within the 3D bone model. They can add virtual abutments sticking up, simulating where the connections for the final teeth will be.
And they can adjust things on the fly? Like playing a video game?
Kind of. The software lets them check everything, the distance between implants, whether they're parallel to each other, which is important for the prosthesis, and they can superimpose the image of the scanning template to make sure the implants line up correctly with the planned tooth positions. If something's not quite right, say an implant needs to be moved slightly for better screw access for the final crown, they can just drag and drop it virtually until it's perfect. It's an incredibly powerful planning workspace.
Once the virtual plan is set, how does that translate to the actual surgery?
There are generally two main ways. One is template-assisted surgery. Based on the final virtual plan, a physical surgical guide is fabricated, often 3D printed. This guide fits precisely onto the patient's jaw and has holes that direct the surgeon's drills to the exact pre-planned locations, depths, and angles.
So very precise guidance.
Extremely precise. The other approach is sometimes called CT-assisted surgery. Here, the surgeon doesn't use a physical guide, but performs the surgery freehand, using detailed printouts or on-screen views of the CBCT slices and 3D models as a real-time map during the procedure.
Okay, and let me guess. Another incidental finding in this case.
You're getting good at this, yes indeed. While examining the entire mandible scan, they discovered another unexpected finding. A horizontally impacted molar tooth way back in the right side of the jaw.
What was special about this one?
The 3D views showed its unique situation clearly. The crown, the top part of the tooth, was actually facing inward towards the tongue, and the roots were delacerated, meaning severely bent or curved and embedded in very dense cortical bone. Using transparency and rotation tools, they could see exactly how close it was to that inferior alveolar nerve. This information is critical if they ever needed to consider removing that tooth, helping the surgeon plan how to do it with minimal risk to the nerve.
And 3D imaging isn't just for the implant site, right? It can help assess where to get bone from if needed.
Exactly. Sometimes, for major reconstructions, you need to harvest bone from another part of the patient's own body. A common donor site is the posterior ramus, the back part of the lower jaw. The CBCT scan provides all the information needed to assess that site too. Is there enough bone? Is it good quality? And crucially, how close is the nerve in that area? It ensures the harvesting procedure can be done safely and effectively.
Can they even simulate taking the graft?
Yes, with the more advanced software, they absolutely can. They can perform virtual surgery, like a segmental osteotomy, virtually cutting out a block of bone of the precise dimensions needed from the donor site, say the ramus. Then they can virtually move that block and position it perfectly at the receptor site where the bone is deficient, all done on the computer before any actual cutting happens. It's incredible foresight.
It really is. So let's zoom out. We've seen these amazing cases. What's the big picture takeaway? Why is 3D imaging considered so fundamental now for maxillofacial surgery?
Well, first and fundamentally, it just blows away the limitations of old 2D x-rays. Distortion, things overlapping, inability to judge with or spatial relationships accurately. 3D imaging solves those problems. Yeah. It provides a clear, undistorted view.
So a completely different level of anatomical understanding.
Precisely. You get accurate assessments of just about everything relevant. Bone width, bone density, exact nerve and blood vessel locations, sinus details, tooth root shapes, the TMJ complex, the precise position of impacted teeth or extra teeth, the true size and extent of cysts or lesions. The list goes on. It's a comprehensive anatomical map.
And having that map empowers the clinicians, right? Does it change what they can offer patients?
Immensely. This level of diagnostic accuracy gives them the information they need to figure out the best treatment options and present them confidently to the patient. It expands their toolkit, improves accuracy across the board, really in all areas of dentistry, but especially as we've seen in complex surgical situations. It builds confidence, both for the clinician and the patient.
So it really boils down to removing the guesswork, seeing the unique reality of each patient before you start.
That's the core of it. Every patient is anatomically unique. 3D interactive data with these sophisticated software tools gives you unprecedented views of that uniqueness. You can inspect every nook and cranny virtually. It just eliminates so much uncertainty. Even something that looks like a simple extraction on a 2D film might reveal hidden complexities in 3D, allowing the surgeon to prepare properly and avoid complications. You're moving from educated guessing to really informed planning.
And how does this ripple through the whole dental practice? What's the impact on the daily workflow?
The impact is huge. It improves how cases are presented to patients that can actually see what's going on. It leads to a reduction in potential complications during and after surgery. It provides excellent medical legal documentation. Treatment planning becomes vastly more sophisticated. Communication between dentists, specialists, and labs is clearer. And ultimately, it often means less discomfort and faster recovery for the patient. It really streamlines and elevates the entire process.
So wrapping up, it seems clear that 3D imaging isn't just some fancy add-on in oral and maxillofacial surgery. It's fundamentally changing how things are diagnosed, planned, and treated. It leads to safer, more predictable results by turning that abstract anatomy into something visible, interactive, and, well, understandable before the surgery even begins.
Absolutely. And perhaps a final thought to leave our listeners with. When you consider this incredible ability to visualize and virtually plan within the complex anatomy of the face and jaw, well, how might this level of detailed foresight transform other medical fields where precision and safety are just as critical? What does truly understanding the reality of anatomy in such detail unlock for the future of all kinds of medical interventions?